guys are taking care of your patients, I'm assuming half of them are women, right? More than half? And probably of them, a tremendous majority of them had probably had a child. Would that be safe to say? So way back when we were in medical school, one of the things they always told us to do was obtain a good history and then do a good physical exam, then develop your assessment and plan. So obstetrical history, believe it or not, might be a precursor to what's going to happen to the woman later on in her life. So it gives us a little bit of an idea of possibly what to look for. So we think it might be the window to future health, good and bad. And by getting that information, it may allow us to customize our surveillance plan for those individuals. And these days, you know, you don't see the patients that often. You might see them once a year. But with some of this information, you may want to change how frequently you see them. You may want to change your plan of action for surveillance. So what we do, I'm a maternal fetal medicine physician, so we see all these patients. A lot of them have reproductive problems, so they see the reproductive endocrine team. They come to us for a consultation after the reproductive endocrine team finds something wrong with them that they may or may not really have needed to have checked. And then it opens up a can of worms for what do you do with them when they're pregnant. But beyond that, once you have the information, you're sort of obligated to use it. So what we're going to do is we're going to describe some complications of pregnancy, which may lead to future problems for health as the individuals get older. And there's a couple basic ones, basically high blood pressure, diabetes, and then there's this recurrent pregnancy loss group of patients that have possibly a growth restriction or fetal demise. And occasionally we have patients who develop thrombosis during the pregnancy. And that triggers an evaluation for the antiphospholipids and also for inherited thrombophilia. So in our world, high blood pressure is relatively common. It affects up to 15% of ladies with their first babies and 4 to 5% after that. It's defined by blood pressure of greater than 140/90 after 20 weeks of pregnancy, on 2 occasions more than 4 hours apart. If it's over 160/110, we consider it severe. Patients with gestational hypertension also have a higher likelihood of developing preeclampsia or eclampsia. This complicates another 5 to 9% of pregnancies. It's defined as a new onset of hypertension with proteinuria or end organ dysfunction after 20 weeks gestation. It's a multi-system progressive disorder. It ranges from moderate to severe, and ultimately the cure for it is delivery. There's a new classification for preeclampsia. It's with features of severe disease, which are systemic manifestations or severe lab abnormalities. The most common things that we see are headache, visual changes, and with the lab abnormalities, you can have increased liver enzymes, increased hemolysis or elevated LDH values or low platelets. And patients with severe disease usually benefit from quick delivery. We also give these patients magnesium sulfate for seizure prophylaxis, and depending on how high their blood pressures are, we may or may not give them antihypertensive therapy. If they have preeclampsia without severe features, then we monitor them closely and we deliver them at term. So with these patients, there are different degrees of hypertension. So when we see these patients and they have blood pressures that are relatively easily controlled, those patients are usually less complex. But if you have someone who develops a severe preeclampsia at 28 weeks gestation, they may have some underlying pathology that may manifest itself later in their lives. So for the hypertensive and preeclampsia patients, we watch them closely postpartum with treatment for blood pressures over 150 over 100. If they do develop preeclampsia, the recurrence risk of hypertension is 20%, and the recurrence risk for subsequent preeclampsia is another 16%. And if they have it beyond, earlier than 32 weeks, those are the patients that you really want to keep an eye on. So when the patients have preeclampsia, their long-term risk for cardiovascular and cerebral vascular disease is increased. For hypertension, there's a relative risk of almost 4. Ischemic heart disease, it's double with a mean follow-up of 11 years. There's an increased risk for stroke, venous thromboembolism. So these patients are pretty sick. And the patients that develop it earlier are even at a higher risk to develop these complications. So when you're taking your history and you inquire about, how many kids did you have any problems, if they've had preeclampsia, that's definitely going to be a red flag for future problems. Now, the absolute risk for any of these between ages 50 and 59 is almost 20%, which is pretty high. So these are the ones that you really want to keep an eye on. And what they think is that preeclampsia may be secondary to impaired endothelial function, and this can cause permanent arterial changes, which could lead to cardiovascular disease later. The other thoughts are that there may be an imbalance of cytokines, genetic predisposition, and also altered cell programming. These patients also have an increased risk of diabetes, regardless of whether they had gestational diabetes in the pregnancy or not. And if they've had preeclampsia and diabetes together, they have almost an 18-fold increase of having a cardiovascular disease. They also have a much higher chance to have underlying renal disease, which may not have completely manifested itself during the pregnancy. So there's a 4-fold increase for that, but the absolute risk for this is still relatively low. But patients with severe preeclampsia below 34 weeks are the ones that you really want to keep an eye on. I keep saying that because that's the one thing that you should really remember. Preeclampsia is bad. If you've had it, you have a higher risk for all this stuff later. And that's part of our counseling, too, when we see the patients who develop severe preeclampsia or preeclampsia. After they deliver, we go see them, and part of the counseling is to notify your primary care physician. We'll forward your records to them, and they just need to keep a close eye on you for these problems as you get older. It may also be a marker for subclinical hypothyroidism, and the thought behind that is that preeclampsia may have some type of autoimmune component to it. So it's reasonable to consider baseline thyroid function studies during the 6-week postpartum visit just to see where their TSH is. If it's on the higher range of the normal end, you may want to consider following it a little bit. If it's less than 2.5 or 2, you're probably fine. The other big thing that we see is gestational diabetes. In pregnancy, there's higher levels of human placental lactogen, which causes insulin resistance during pregnancy. And the physiologic basis for that would be to have slightly higher glucose levels available for the developing fetus. So whatever the glucose values in the mother are the same in the baby. This hormone peaks at around 22 to 30 weeks. So in pregnancy, we screen patients usually between 24 and 28 weeks. The levels of the hormone normalize after delivery, and hence after you deliver a gestational diabetic, usually their glucose values come down after the effects of the hormones have dissipated. Sometimes we detect pre-existing diabetics if you do a screen and their values are very high, like with the 1 hour glucose screen. Usually if it's over 200, we start considering them possibly a pre-existing diabetic, and it may actually change the way we manage that index pregnancy. And there's probably, depending on your lifestyle, if modifications, whether you implement them or not, you could have up to a 60% risk of recurrent diabetes in your subsequent pregnancy. So about 20% of these people have some type of impaired glucose tolerance during the postpartum period. The risk for metabolic syndrome increases, after 3 months if these values don't normalize. And there's a high correlation with type 2 diabetes. And that's where the modification of your lifestyle, counseling may have an impact for some of these patients. It may not prevent them from developing diabetes later, but it may delay the onset of their disease. So if you're able to have these patients get into a better exercise and nutrition regime, you may help improve their overall health. And these are the patients also that you want to keep a close eye on. And you look at body shapes. Sometimes some of these patients have a slightly bigger waist. Those are the ones that are going to have a higher chance of having it when they get older. So as part of the routine pregnancy care, you have a glucose challenge 6 to 12 weeks after the delivery. If the fasting values are between 100 and 125, those patients are considered having impaired glucose tolerance. Greater than 125 is diagnostic. Some people use hemoglobin A1Cs as screening tools to evaluate these patients also. And if you have gestational diabetes or have had it in the past, it's reasonable to rescreen them every 3 years just to see if their status has changed. Once again, the lifestyle modifications, weight loss, exercise, nutrition, and possibly even medical therapies may help with these patients. We're going to talk a little bit about nutrition in another lecture, but during pregnancy, what we're trying to have the patients do is have a diet that consists of about 40% carbohydrates, 20% protein, and about 40% fats. Some of the earlier work on diabetes stressed more of a 60% carbohydrate, 20% protein, 20% fat type of diet. And I don't have really a slide for this, but if you drew curves of average glucose values, the higher your carbs over like the 4 to 6 hour window with that higher carb diet, your baseline glucose level would actually be higher. So by modifying your diet, you're going to have lower carbs up front, and you end up getting more of your glucose values, your mean glucose value throughout the day, just by changing your diet, would be lower. And that, with exercise and hydration, might be enough to keep your levels in range. So the long-term risk from gestational diabetes, once again, with the type 1 diabetes, there may be a genetic predisposition. That's more likely if the patient is lean and they require medical therapy. So going back to the management of gestational diabetes in pregnancy, we have two types. We have patients that are controlled just by diet where the modification in activity and the ratios of what they're eating are good enough to keep their values controlled. Those patients may be a little less severe. They may develop diabetes later, but those are the ones that the lifestyle modifications may help more. The other class, we call them A2. So there's A1 diabetes, which in pregnancy is controlled by diet alone. Then we call A2 diabetics are patients who are not well controlled by diet and they need medical therapy. So those patients are probably a little more severe. And they may require medical therapy later on in life. But even with them, there's increased risk for cardiovascular disease. And even with mild disease, these risks continue with them as they grow older. Now we're going to switch gears a little bit and talk about some of these other indications that patients get screened for. So when we see patients, we see them for many different reasons. When patients have recurrent pregnancy loss, sometimes there might be pre-existing conditions which may benefit from therapy to help them with their reproductive capacity. Sometimes we have patients that have a growth restriction or an adverse pregnancy event. So when you have growth restriction, you start evaluating the moms and the uterus for various conditions. If someone has a fetal demise, like at term or preterm, that triggers a big evaluation, as well as when the patients have like a thrombosis. So with these patients, there might be either an acquired problem or a hereditary problem, which led to these catastrophic events for the mother. Recurrent pregnancy loss isn't that common. It affects 1 to 2% of all pregnancies. Growth restriction is more common. That's about 5% of pregnancies. Fetal demises, maybe 4 to 5 per thousand. Embolic event thrombosis is not that common either, about 5 in 1,000. But with pregnancy, you have a hypercoagulable state, so there may be different causes. You have venous stasis. You have increased level of clotting factors. The uterus shifts over to the right side because of the colon, which causes stasis in the left lower extremity, which is the most common area for the development of a DVT in pregnancy. And when these events occur, we do the evaluation. Sometimes when the patients are undergoing when they're having infertility issues, some of the reproductive endocrinology people do a pan evaluation on the patient because they want to try to uncover any problems. So sometimes some of these conditions are detected. They may or may not be clinically significant, but now we know about them and we have to address them. So antiphospholipid syndrome is characterized by both arterial or venous thrombosis or specific pregnancy complications and laboratory evidence of elevated lupus anticoagulant antibodies, anticardiolipin antibodies, or the anti-beta-2 glycoproteins. Do you guys see that a lot in your practices?
What about OCs? When do you screen the people you're going to put on oral contraceptives for thrombotic disorders like this?
Okay, well, great question, of course. So when patients have these findings, we usually have the event first, and then we counsel them, and these are the patients that you really want to explain the pros and cons of hormonal contraception, whether it's going to be a birth control pill with estrogen and progesterone, possibly progesterone only type therapy, possibly like barriers or like an IUD without any hormonal therapy. But that's part of the discussion that you have. The same thing with the hereditary thrombophilias, which we're going to talk a little bit about. But that's part of the after counseling. So once you have this event and the patient has the baby, we talk to them a little bit about future pregnancy risks, because if they had a bad event with the one pregnancy, like a thrombosis, if they get pregnant again, they may run into the same event. So, but these are the things, these are the screening tests for the antiphospholipid antibody syndrome. The problem is sometimes we get patients with positive values, which should be repeated twice, 8 weeks apart, but they don't have the syndrome, but they have the positive lab. So now you're stuck with, what do you do with these patients? And even after delivery, you can't just forget about the lupus anticoagulant antibodies that the lady had twice when she was pregnant. Now she needs a hysterectomy because she has fibroids, she's done having kids, and they forget to tell the surgeon, and then she develops a thrombosis, like a deep vein thrombosis after surgery. And then they say, hey, you know what? I remember when I was pregnant that I had this lupus anticoagulant thing. I don't know, they gave me heparin and aspirin for it when I was pregnant, but I forgot to tell you. Well, guess what? Now you have a blood clot and everyone's like unhappy. The patient, you know, it may have been prevented if everyone knew about it. You know, and I think that's where the EMR is going to help us too a little bit, but then you actually have to look through the 8,000 pages of the EMR to find everything out. So, you know, we have a lot of work to do, but we're getting better. So for the criteria for antiphospholipid antibody syndrome are greater than 1 loss after 10 weeks with no explanation. So at 10 weeks you actually have a bit of an embryo, so we call it an embryonic demise. But it's very common to have losses before 9 weeks. So that's why they used the 10-week rule. So if it's beyond 10 weeks or beyond, it's reasonable to check the patient for antiphospholipid. If you have a preterm birth before 34 weeks with severe manifestations, evidence of uteroplacental insufficiency, which is usually small baby, low fluid, small baby with abnormal Dopplers before 34 weeks, that makes you wonder whether they have something else going on. So that would be a reason to screen. If you have, I'm sorry, I messed up my slide, but if you had greater than or more than 3 losses, less than 10 weeks with no explanation, that's a reason. And if you have a fetal demise, an unexplained fetal demise, that would be another cause to perform this evaluation. So what we do for these patients, the biggest thing we worry about with them is thrombosis. So if we have a patient with known antiphospholipid antibody syndrome who's delivered, we continue them on thrombosis prophylaxis, which in our world is either heparin or Lovenox with an 81 milligram aspirin for 6 weeks postpartum if they had a natural delivery. If they had a cesarean delivery because of the increased risk for clotting, we usually suggest 8 weeks. If they have an arterial or venous thrombosis, some people would suggest giving them lifelong anticoagulation. So it's important information to obtain from these patients. It's not that common, but when it happens, it could be pretty bad. They have increased risk for thrombosis, increased risk for stroke. We just talked a little bit about the estrogen-containing compounds that should be avoided for both contraception and even later on for hormone replacement. There's increased risk for, MIs. So, sometimes when we have discussions with the patients, it depends where they are in their reproductive career, so to speak. But sometimes we suggest staying on an 81 milligram aspirin, which, has possible benefits. It's pretty low risk. It's not going to hurt you to have an 81 milligram aspirin. We stress that they should. We provide this information to their obstetrician. But sometimes they have other surgeries, like if they have an appendectomy, if they have cholecystectomy, they're out of the OB world now, and they're with a surgeon. Are there any surgeons here? Okay. Well, we know that surgeons don't usually take the greatest histories, at least when we were students they didn't. I'm sure they're much better now at that. But, you know, if for patients undergoing surgery, if it's not through the care of their internist or their primary care provider, they may not get this information, and it could lead to catastrophic effects. So it's important for the patients to take ownership of their conditions, but it's also in our best interest to try to provide and pass the information along to the caregivers. The other thing to consider is patients with these conditions, as they get older, they may develop some type of cancer. Cancer raises the risk for thrombosis also. So a patient with stage 1 breast cancer that had a history of thrombosis or antiphospholipid antibody syndrome in the past might be treated differently by the oncology physicians than someone who never had that history. So there is a role for thromboprophylaxis, whether it's lifelong or targeted, but these are things that are important for everyone to know. So that would be the acquired conditions. There are also inherited thrombophilia conditions that increase the risk of thrombosis. These are usually venous in nature, and they sometimes are amplified during pregnancy. So the ones that we're going to review today are the factor V Leiden, prothrombin gene mutation, protein S deficiency, protein C deficiency, and antithrombin 3 deficiency. So factor V Leiden is a single point mutation in the coagulation factor V. It's the most common risk factor for patients with a thrombosis, and it's found in about 20% of these patients. In the pregnancy world, when patients are screened for these findings, if they're homozygotic, then we treat them. If they're heterozygotic, which is a 5 to 7-fold increase, those patients, we look at their whole history. So if they've had a child before and everything went well, those patients may not get any prophylaxis during the pregnancy. If they have other risk factors, then sometimes we might even prophylax them. But the important thing for the heterozygote is that they need to know that that is their status, because if they have surgery, it's recommended that they receive prophylaxis. So the heterozygotes are the ones that kind of get washed under the rug, because we didn't treat them in the pregnancy because they didn't really have a problem, but then they go and have some type of surgical procedure, and then they may develop a problem from that. The homozygotes definitely have an increased risk, and the highest risk in pregnancy is during the postpartum period after pregnancy, right after you deliver, and it's increased 6 to 8 weeks after the delivery, and even in males, it may be increased with leg trauma. So here's where genetics comes in. It's a genetic condition. So if you have it, either you're homozygote or heterozygote for it, you have a child, your child may or may not have this factor V Leiden issue. So you don't need to, I'm not saying you need to check the child right away, but if the child requires surgery, or at some point it may be, if it's a girl and at some point she's thinking about contraception, this would be something that you might want to consider screening the child for, because the mother has it. And these are the things that we need to go beyond our own patients and start thinking a little bit about the family, the whole family care. So even with a boy or a girl, you still need to know what the status of the person is for their future complications that may occur as they get older. You need to have this information so you can make a better plan. Prothrombin gene mutation affects about 1% of the population. Almost 20% of patients with a thrombosis have this mutation. It raises your risk for clotting for thrombosis 3-fold. It's associated with other disorders like cardiovascular disease, stroke, mesenteric vein thrombosis, portal vein thrombosis, central retinal venous thrombosis. These are pretty serious complications that can occur. So when we have patients that develop these problems because of a pregnancy loss, this is the kind of information that we need to be aware of. Protein S is a vitamin K dependent protein. It's very rare. It's more likely if you have a family history of thrombosis. And once again, that's where the family history helps you a little bit. Not only do you want to know the pregnancy history, but if there's a strong family association of clotting or thrombosis, these are the patients that you may want to screen. It may also be associated with chronic liver disease, lupus, and ulcerative colitis, so it may have an autoimmune aspect also. And in pregnancy, these proteins vary. So the screening in pregnancy, usually the lady's pregnant, she gets a blood clot, we do this evaluation. It's really not the most accurate time for some of these tests to be drawn. So we know that protein S usually goes down in pregnancy. So if you were not pregnant and you had a value in the low range or in the beyond the lower part of the normal range, that would be considered diagnostic. In pregnancy, because it goes down anyway, it should be 50% lower than the average low end of the scale. Protein C is usually constant in pregnancy. It affects up to 8% of the population. If you have a homozygous presentation, you can get like microvascular thrombosis. And once again, the protein C might be affected by liver disease, preeclampsia, contraception, and even anticoagulants. Antithrombin 3 deficiency is probably one of the stronger, it has a very strong correlation with thrombosis, but it's pretty rare. It's autosomal dominant. This is another one that if the mother has it, you want to start talking about other family members and kids. It affects, up to 5% of patients with a thrombosis, and this has a high risk for arterial and venous clotting. So with any of these inherited thrombophilia, you have a higher risk of thrombosis for your whole life. It's an opportunity for counseling the adults and children for possible prophylaxis during surgery, counseling regarding contraception, hormone replacement therapy, and it also might be helpful for the management of the pediatric patients undergoing surgery if you have the luxury of screening them first. And then that's a discussion that you also may want to have or the patient may want to have with the pediatrician to find out at what age do I need to know this. I have antithrombin 3 deficiency. It's autosomal dominant. When should I check my kids? So what can we do for these things? Well, exercise is always good. An increased BMI is another risk factor for thrombosis. So healthy lifestyle, good nutrition, having a diet with possibly lowering your cholesterol might be beneficial. Losing some weight. Some people feel that, and for some of these conditions, an 81 milligram aspirin may be of some benefit. It may have other benefits as well. The omega-3 vitamins or supplements, we just were talking about how they might be helpful in pregnancy, but they also have anticoagulation effect with them too, so they're good for circulation. They may have a positive effect on the cytokines, which can be associated with some of these inflammatory reactions. And also venous thrombosis prophylaxis for surgery. where these days everyone gets the SCDs now, the sequential compression devices. But possibly for patients with these conditions, you may want to add some type of heparin or anticoagulant prophylaxis for a period following the delivery, or in addition to the sequential compression devices. The other things that may correlate a little bit with patients' risks for disease as they get older is their birth weight. And this is something we're going to talk about, I think, on Thursday, but it's pre-programming in utero. As you develop as a fetus, you're being programmed by your genetics and your environmental, your in utero environment. So if you were a small baby, you might have some underlying vascular, autoimmune, and endocrine alterations which predispose you to medical conditions as you get older. The same thing is true for if you were a really big baby. Now, those records are a little bit harder to come by because you might not know how much you weighed when you were born, but it's not an unreasonable question when you're evaluating your patient to ask them, do you know how much you were when you were born? How many weeks were you? Then when you go into the obstetrical history to get some of the complications that may have occurred. So we discussed high blood pressure and preeclampsia. So those are important things to ask your patients if they're women. Gestational diabetes, we discussed. The antiphospholipid syndrome, thrombophilias, birth weights. All these conditions require further investigation and possible surveillance. But when you obtain this information, this will give you the opportunity to customize your management plan to meet the needs of the individual. We talk about all these algorithms and all these care plans that we have for these big groups. The problem with that, it's great because it makes you think about, where you want to put the patient, what category. The problem is that people have more than one category, and there's nothing that really fits everybody. Not everyone's a square, not everyone's a circle. So we have to modify our care plans to benefit the individual. We take population statistics and we try to apply it to an individual patient, but you really can't do that. All you can tell the patient with that information is that in big groups, this strategy seems to work. I don't know if it's going to work specifically for you as an individual, and then you modify your plan based on that information. So although New Jersey is not as beautiful as South Carolina, we do have sunsets there, and this is from Cape May. So this is the best sunset in New Jersey. Well, thank you.
Okay, so Mary Jo comes in and she says, I want contraception. I'd like OCs. And I say to her, you ever had a thrombotic event? She says, no. Now I should probably say, and did your mom have any one of the following?
Well, I think it's reasonable to expand the question one more time as you suggested. So if she had a normal pregnancy and she had no problems.
She's not been pregnant.
She doesn't want to be pregnant. You're right. Okay. Yeah, I would get a family history, and I would ask about the mom and any of her siblings, if she has any sisters or anyone. But it would be reasonable to get a history from the mom also. And if she has any of those risk factors, then you would consider screening her, the patient, for that prior to making your suggestion. And nicotine patches are okay. No, I'm just kidding.
Please remind the audience to the non-use of Coumadin during gestation. I've seen one midline defect that was as terrible as anything when a person was put on Coumadin instead of using heparin or heparinoids to prevent the problem, and it's a total disaster. So, as you know, Coumadin is an absolute no-no during pregnancy.
Well, it depends, like everything. Yes, you are correct, but in some conditions, for instance, if the patient has a mechanical heart valve or something like that, what they do is they use heparin or Lovenox in the beginning of the pregnancy, and then when the fetus gets to a certain gestational age, they may transition them to Coumadin after the baby's completely developed. Because sometimes you gotta like always, this is the tough thing with anything, that you always, at least what we do maternal fetal medicine, so we always take care of the mother first. So we would say, look, the studies show that Coumadin is better if you have a mechanical heart valve, and she may say, I don't want Coumadin, then we'll say, okay, Lovenox isn't as good, but if something happens, but you know, for prophylaxis, usually we stay away from Coumadin. We don't use Coumadin. We use heparin, we use Lovenox, and some of the other low molecular weight agents. But in rare circumstances, sometimes we even do use Coumadin. But I haven't seen Coumadin in 18 years. So, well, thank you. Thank you very much. Good. That's good. Oh.
Be good to make a quick announcement. There are flowers out on the table for Medical Dilemmas in Patient Care 2015 update in New York, December 18th through the 20th. It's an excellent conference chaired by Dr. Basil, who spoke earlier. Friday, hypertension, COPD, hepatitis C, cholesterol guidelines. Saturday, jaundice patient, pulmonary hypertension, heart failure, and Sunday, infectious diseases, pulmonary diseases. So it's a really good meeting. December in New York is beautiful. So if you're interested in that, pick one of those up out on the table.
Okay. Well, thanks for hanging in there. I'm assuming we have an experiment this year to talk about some OBGYN topics in the primary care room, that most of you aren't doing deliveries. Is that true? Who in the room is doing deliveries? Okay, there are a couple. Most aren't. So what I tried to modify this talk and look at things that, again, for 25% of the pregnancy, they haven't gotten to a OBGYN, or if somebody's going to deliver, a family medicine who's going to do the delivery. So you're seeing them in your practice. Also, patients who have a disorder, then they have questions about how this is going to affect my pregnancy and what do I do to get ready for a pregnancy. So I've tried to tailor it to that, but again, there's reasonable sized groups who just interrupt, not really interrupt, just raise your hand and we'll talk about it. Again, there were some recent changes. We talked about the major changes for the STDs, but the CDC guidelines also look at pregnancy for each of the diseases. Not all the diseases are STDs, and then ACOG has their opinions too. So if you want to look, again, they're brand new, and they're the references, and they'll be online. So there are mandatory tests to do in pregnancy. These are things that you're supposed to do. If you don't do it, you're going to get in trouble someday. So Group B strep, we know. Even though the Infectious Disease Society for OB/GYN doesn't believe in screening for Group B strep, the pediatricians wanted it, and ACOG and the CDC wanted it. But the prevalence is about 20% in all pregnancies. If you have Group B strep in pregnancy, there's a 1% chance something bad is going to happen to your baby. So we're treating 99% of the women with no benefit. I think there's a consequence to that antibiotics in that 99%. The data, when I started in Emory and finished with the New England Journal article with Barbara Stoll, shows that we develop resistance and an increase in E. coli rate, and E. coli is a bigger killer of babies than Group B strep. So it was about 3 years ago, the tide had turned because we're treating everybody with Group B strep. So the number one killer, to the board question for OB/GYNs, the number one killer of babies, infectious killer of babies, is no longer Group B strep, it's E. coli, and it's caused by the overuse of antibiotics. But they're there, they want you to screen, they want you to treat. Gonorrhea, chlamydia hepatitis B surface antigen. We'll go through each of them. Syphilis, HIV, as you know, is an opt-out. Hepatitis C, urine culture. You do have the option of just doing a dip and a screen, although the United States Preventive Service Task Force says the culture is better to do than the PAP according to guidelines. So again, the CDC lists it under special populations, and again, they say you should ask them about STDs, counsel them about the possibility of an infection during their pregnancy, and provide access to screening and treatment. So you're in their office, you're doing a pregnancy test, which we'll just talk about in a minute, and your pregnancy test comes back positive. There's certain things you need to discuss and do right then in time before you send them off for delivery, or you do deliveries yourself. So the recommendations are based on severity, sequelae, prevalence. They even talk about medical legal considerations, especially state laws when that'll come into play with mostly syphilis. And the screening recommendations are broader. That means when you think you know them for your STDs in your patients, for pregnancy, there's more recommendation. There's always a little caveat. So each disease has a special section for pregnancy. So don't just rely on what you do for non-pregnancy. So HIV, all pregnant women should be screened at their first prenatal visit, even if they have been previous tested. So last year they were pregnant, the HIV test was negative. You say, we're going to screen you for HIV. They say, no, I was screened last year. You need to tell them that no, it's recommended for each pregnancy, and that's the opt-out. They go further and they said even if they say no, you're supposed to take it further, address their objections, and continue to encourage testing. If again, they say that I had a negative test before, you got to tell them that it's important to retest in every pregnancy. They really want to decrease the risk and go further. Again, retesting in the third trimester at 36 weeks is recommended if they're at high risk. And high risk, they're very specific about this in hepatitis C. High risk is illicit drugs, STDs during pregnancy, multiple sex partners during the pregnancy, live in high areas of HIV prevalence, or have partners with HIV infection. Some of those are obvious, but again, someone that says, they have had 2 partners during their pregnancy, or they develop, the test comes back for chlamydia positive, even trichomonas, which is an STD, then you need to retest them in the third trimester. Rapid HIV screening should be performed in labor. So if the patient comes in labor and she never, so you're in the ER, and she comes in labor, and you're drawing the first labs before you send them off to labor and delivery, include a rapid HIV test in there. And if it's positive, they should be administered prophylaxis and waiting for the confirmatory test. And syphilis is again performed in all pregnant women at their first visit. When you don't think that their access to prenatal care is good, they pop up in the ER. They rarely show up for their follow-up appointments. The CDC wants you to do the rapid test. Most labs don't do that anymore. And begin treatment if that test is reactive before they leave the hospital. And it should be performed at the time of pregnancy is confirmed. What that means is we're trying to increase our volume of OBGYN patients, especially OB patients. The best and easiest way to do it, and we did it in Oklahoma, is to have a free pregnancy test clinic. You have a free pregnancy test clinic. They come in, and then they come in because they think they may be pregnant. 20% of them are. Automatically you say, fine, we'll sign you up and make an appointment in our office. But when they're there, you need to make sure that you screen them for syphilis, or you do the rapid tests and then treat them before they go. It's not easy to do. It's one of the things that limits our expansion of our pregnancy screening program, our pregnancy test free pregnancy test program, but this is new. It's in the CDC guidelines now, and you really need to screen for syphilis if you think they're historically not good at following up. Women are at high, and it's important because even though they say, I'm going to definitely have a termination, 20 to 40% of those don't wind up getting a termination, and then now you have a patient that has syphilis already for 20 weeks, can't or decided not to get a termination. They've had syphilis during that whole time. And again, if you're at high risk, they want you to screen again at 28 weeks. Remember, 36 weeks for the HIV, 28 weeks for syphilis. Syphilis, you're going to catch it earlier because you can treat. HIV, you just want to prevent the delivery, the infection at delivery. So the timing is different. Some states require all women to be screened at delivery. Regardless, they're not supposed to let the baby go home unless they have a negative test on the chart. So it could be from your office, and sometimes you'll get a call from the nursery saying, we don't have a negative test for this patient. Do you have one in your office? And hopefully it'll be on your prenatal record. If not, they will draw one at a time, and the baby won't go home. And again, for anybody who has a stillborn, you need to rule out syphilis as the cause. The problem comes in now, again, we're talking about laboratories, that it used to be you get an RPR or a VDRL, and if it's positive, 50 to 75% of them are true positives, 20 to 50% are false positives, and that's just the nature of the test. It's not the difficulty with the lab. It's looking for cardiolipin, not for syphilis itself. They then will do a confirmatory test looking for antibodies. The problem is that labs want to do the cheapest way, and the cheapest way is to stick it on a machine and check for antibodies first. Again, there's a 50% false positive rate with the antibody test, and so a lot of us are seeing that you've got an increase in your positive syphilis reports back for your patients. Now, 50% increase, you may see one a year, 2 a year, you're going to see 3 a year, and 2 or 3 a year, but it's more than you've seen before, and that's because the labs can find they can screen hundreds because the RPR it's a flocculation test. It's harder to do, so they're just doing it reverse. The CDC doesn't like it. Again, they can't tell the laboratories what to do. They can only report it. And in the CDC section on syphilis, they explain that they've done the studies. There's 50% false positives. You're going to have a lot of false positives. Just be aware of that. But they can't force the laboratories to change their methods. They just have 2 tests. They're going to switch the way they do them, and they can do that. But if you start noticing even 1 or 2 more, the problem with the patients come to me after 2 doctors have already told them they have syphilis. They don't have syphilis. They're really upset about it. Then they start looking at each other and said, did you give it to me or did I give it to you? And again, it's a false positive. So if you do have the VDRLs and the RPRs, the next question is, it comes back positive, and they say that, gee, I had it 5 years ago. If they had a primary, the RPR goes back in 12 months. Even secondary, it's back in 24 months. So if they said, oh, it's always positive. The antibody test will be positive almost forever, but the RPR and the VDRL will revert back to normal in 24 months. So if they said I had syphilis 3 years ago, and their titer back then was 1 to 16. And now it's 1 to 8, 3 years later, they've gotten syphilis again, probably from the same place they got it before. Treatment is penicillin, you know that. The fun stuff is if they're really, truly penicillin allergic, we desensitize. Again, I'm a strange person. For me, it's fun. You basically take someone that's highly allergic, you bring them into the hospital, hopefully close to the ICU. You give them little doses of penicillin. You wait for them to get a reaction. You give them half an hour later, give them a little higher dose, wait for a reaction, keep doing that, with increasing dose. Finally, one time, they don't have a reaction because you've degranulated all their cells, their white cells, and then you give them the big dose, and that lasts for about a week, and then you bring them back again. But you're basically playing not so much Russian roulette, but you're running on the border. So it's an exciting thing for OBGYN infectious disease. See, we have that's all the fun we have. The hepatitis B, again, they're very serious about it. All should be tested for surface antigen in their first prenatal visit, even if they've been vaccinated. So you don't say, oh, I got the vaccine, that's it. They get screened. And again, you'll have a panel for your pregnancy. Yes, it's just that some of them are different. They may have done earlier. You'll do the syphilis earlier than you will the other. Remember, you've seen recommendations for do them immediately once you know they're pregnant, and do them at your first prenatal visit, and then do them at 28 weeks sometimes, and do them at 36 weeks sometimes. And again, it's very simple. Just go to cdc.gov and see that, and modify your panels that you have in your EMR for screening for pregnancy. Women who are not screened prenatally, that put them at high risk, and high risk is it's different for each disease. So high risk is having more than one sex partner in the previous 6 months, and if they not just were treated for an STD, but they had an evaluation for an STD, and that's easy to document. If they had a test, even if it was negative, you evaluated them for an STD for a reason, and in drug use and hepatitis positive partner. But again, they're very liberal. Again, as I said, they're going to be more recommendations for people who are pregnant. So if they're documented to say, I had a different sex partner 5 months ago, and they've just got pregnant 1 or 2 months ago, you're going to have to screen them prenatally. Hepatitis B, again, if they're at risk and they haven't been vaccinated, you should vaccinate them. You can vaccinate them during pregnancy to avoid the misinterpretation. Draw the tests first, and all laboratories need to confirm it. Again, there's inexpensive tests they want to confirm because it's a serious diagnosis. And again, if they're tested at the time at admission for delivery, they want you to do just call your laboratory. They're going to do their shortened testing protocols, and again, immediately they should need to administer immunoprophylaxis to the neonates before the final test results come back. You report them. The laboratory will probably do that, but they should report them to the local state health department, and they'll start putting them in the case management. A high percentage of those, the babies will develop, unless they're given the proper prophylaxis, will develop hepatitis B, and they'll develop chronic hepatitis B. If you have information about their status, you should provide it to the hospital that's planned so they can do a better planning. All household contacts with someone should be vaccinated, so it's your responsibility. You screen, they're positive, you have to say you need to go and get each one of those, your household contacts vaccinated if not vaccinated already. We're developing a separate site for all the vaccinations because you have to give Tdap now in pregnancy and flu vaccines during flu season. And it's hard for every office to stock all the vaccines, so we'll just have a central location since we're a large employed group to go and get all the vaccinations. And we're now sending their partners. We'll send the grandmothers for Tdap, and we'll send the family members for influenza. And again, appropriate counseling. Hepatitis C, these guidelines are upgraded recently. They really take women who are at risk, not everyone, but everyone's at risk for hepatitis C should have hepatitis C screened. We don't usually do that. They're very specific about what the risk factors are. So it's drug use, it's a blood transfusion before 1992, and fortunately a lot of these women aren't getting pregnant now, but there may be some. Receipt of an unregulated tattoo. What's a regulated tattoo? Well, in Oklahoma, until last year, there were no tattoos allowed in Oklahoma. So if they got them, if they didn't go over the border to get it some other state, they were unregulated. There's very specific regulations of tattoo parlors. The instruments have to be cleaned. I think the patient has to be drunk. There's a very serious things you have to go through to get a tattoo in most states. So, but if it's unregulated, they say my cousin does them in his garage, then that's a hepatitis C screen for that person. Long-term dialysis, intranasal drug use, and other percutaneous exposures. Again, not just injection drug use, but intranasal drug use. All women with hepatitis C infection should receive appropriate counseling, and no vaccine is available, so as you know. Pap testing, we talked about Paps next door this morning. I saw some of you came back and forth. It's the same as non-pregnant women. As we mentioned earlier in the other room, the ASCCP, the guideline group for Pap smears, say that age supersedes pregnancy. So if you're pregnant and under 21, you don't need a Pap smear. ACOG's the other way. All pregnant women should get Pap smears. So you can, I figure if they're pregnant, that means they're having sex. If they're having sex, they could have HPV, and if they could have HPV, they could have an abnormal Pap smear. So you have two. You can go both ways on that, but that's why I included. You probably should get a Pap smear for almost everyone. The chlamydia, just the pretty much the same routine recommendation before. All pregnant women less than 25 at increased risk should have a test. Again, ACOG says all pregnant women, regardless of their age, should be screened. But again, between CDC and the United States Task Force, if you don't do them for a 30-year-old that's at low risk, that's acceptable. I think it's pretty routine that we test all of them. If you're at increased risk for chlamydia, as mentioned before, and again, those guidelines are even more broad. So if they've had a new sex partner, more than one, so if they're pregnant with the new sex partner, that counts. If they've had more than one sex partner, if they have a partner that had another partner, which you don't really know, or a sex partner that had a sexually transmitted disease, you should routinely screen them. And that's why pretty much we screen everyone. If you're, again, at risk, you should test them again in the third trimester. And again, if you're pregnant and you have chlamydia, you need to have a test to cure, and you need to wait for that test to cure for 3 or 4 weeks. Remember, about 14, 21 days, the RNA or DNA, depending upon what the specific test looks at, hangs around after the cell has been destroyed. So you'll get a positive back if you test them sooner than 3 or 4 weeks. And then when you retest them, say in a month to 6 weeks, you retest them again at 3 months. The retesting again in 3 months is because about 30% will be positive, will get reinfected because, again, the person that's the third person in, or fourth or fifth in the relationship probably hasn't been treated. I had a patient with chlamydia. She said, I said, I'm going to treat your husband. That's a question yesterday, do you treat the partners? This is what kind of told, I said, and then yesterday I told you, I did for a while, I didn't, I did for a while, and I didn't. So when I was doing it, I gave a prescription for her partner. Her husband calls me up and says, oh, by the way, I have a girlfriend, will you treat her? And I said, well, I'm a good STD person, I'll go ahead and treat her, not seeing her. She calls me up and said, I have a husband, said, could you treat him? And then it went to 7 generations. Then I finally said, stop, I can't stop. I can't do this anymore. So there's a good chance that they're going to be reinfected unless you catch all the partners. That means everybody's got to be telling the truth, and the reason you got here is because somebody wasn't telling the truth, usually. The diagnosis, the nucleic acid tests are okay. Remember, as we talked about yesterday, they're in a general routine nice practice. If you have your rate of chlamydia is about 1 to 2%, and therefore your false positive rate's about 60%. And the reason this is if you look at the general distribution, you take a look at 1,000 patients and you screen them, there'll be a distribution of the test for the people who are positive. The way they do the test is they attach a floor to a sequence. Different tests may have 5 nucleotides they look at, 6 nucleotides they look at, or 3 nucleotides. If it's 3 nucleotides they look at, then there'll be a lot of false positive because other things will mimic it. Example is Neisseria gonorrhea. If you use a short nucleotide, it's going to be mimicked in Neisseria meningitidis, which is probably 1 to 3% of all vaginas, maybe 7% recently when they looked at the data. So you'll get false positives. If you decide you want to be more specific, that's great. You go to 6, 7 nucleotides, but then there are a few you'll miss that because you broke up. The first step you do is you break up the DNA, and if you break into too many small pieces, you'll never get the 6 or 7 nucleotides. So you'll have more false negatives with that. So when you do look at the whole spectrum of 1,000 patients, there's a regular Gaussian curve. There'll be 2.5%, that'll be false negatives, and 2.5% be false positives, the wrong result. The FDA says you just need to have 95% accuracy. So you have 95% accuracy. You take the middle 95. So your laboratory says if the light source is 0.00426 to 0.00474, that's the 95%. That's what we're going to call a positive. You'll miss 2.5% false positives. You'll miss 2.5% false negatives. So if your prevalence in your population, if you have a nice practice, it's probably 1 to 2%. The true prevalence is 1 to 2%. Let's just say it's 2.5%. Okay, you're on the borderline by the railroad tracks. So it's 2.5%. So when you get a positive back, there's a 2.5% chance that it's a true positive, and a 2.5% chance that it's a false positive. So what's your rate? What's your accuracy? 50%. So every time you're under the 2.5%, then you go from 50% accurate to 40% accurate to 30% accurate, and the false positive rate goes up. That's why it happens with all these tests, because it's a straightforward statistical analysis for that 95%. So you screen them. Remember, if you have a nice practice, there's a 50-60% chance that test you have for that patient is going to be false positive. You then, according to their recommendations, you're supposed to, you don't tell them they have chlamydia, you're supposed to check it. Now, if it's high risk, you say, yes, I have 3 boyfriends, my boyfriend's chlamydia, you just treat him and it's over with. But if they say, no, I really don't think so, and probably, like I said, 10% of my practice are people coming in saying, my husband swears he's not cheating me, my test was positive, and I go ahead and work through it and culture them and take care of it. If you want to confirm, you need to confirm with a different nucleic acid test. The problem is, you send your test to LabCorp. LabCorp has one machine. They will run the same test all over again, and you'll get the same false positive. You're supposed to make sure they get the different test, which you're not going to do. You got to say, I got to send it to a different laboratory, and I got to make sure they're going to use a different test, and it's very, very difficult to do. But that's your diagnosis. So again, you diagnose chlamydia. With a nucleic acid test, there's a very good, in your practice, a very good chance that it's a false positive. Again, different sensitivities and specificity based on your practice incidence. Recommended therapy, you all know it. I just like to keep telling you, it's azithromycin 1 gram oral once. There's alternative regimens. I developed the amoxicillin regimen, and as soon as I developed it, I changed my mind. So we did in my fellowship and right afterwards, we would get chlamydia, we cultured for it, we grow it on plates. One of my fellowship projects was we just give it penicillin, we see that it wipes out the chlamydia, and that was great. We talked to the CDC people, said we're friends with them. They said great, they put it in the recommendations. And then what I did afterwards is I took that plate and I regrew it and I regrew it and I regrew it. And on the 7th passing through, it all came back to life. Because chlamydia is not an organism that survives by binary fission. It makes elementary bodies, gets into a cell, makes elementary bodies. And so the elementary bodies can stay around and then they can grow back if they're not killed. And amoxicillin suppresses them but doesn't kill them. So during pregnancy, you give them amoxicillin, you'll be able to suppress during pregnancy, but 7 generations, which is about 21 days, it can come back. So you have to retest them all. Erythromycin is very, very good. Just difficult to take in pregnancy, but the alternative. But if you see you look it up and say, I'm going to use amoxicillin, I tried the erythromycin first, but if they don't want to tolerate the erythromycin, amoxicillin is fine. Gonorrhea, same thing. The CDC gives you the option of saying that if they're over 25 and they don't have any risk factors, you don't have to screen them for gonorrhea. But again, risk factors are a new sex partner, more than one sex partner, recurrent partners, and a partner who had sexual extremities. There's a lot of ifs. So unless you want to spend a lot of time saying, do you really think your husband, doesn't have a girlfriend, which I don't even want to ask about, I just say they're pretty well acceptable. It's that too, just having their screen during the pregnancy. Again, additional risk factors include inconsistent condom use. How many people use condoms 100% of the time? In women that they're not mutually monogamous relationship, previously or coexisting sexually transmitted disease, so they've had trichomonas 3 years ago, and exchanging sex for money or drugs, which the patient will know about. And they may not tell you, but they'll know about. So I think the guidelines are pretty broad. They want to make it so you don't have to screen. I think this, the CDC, they're really trying to help. So if you don't screen because there was no risk factor and the patient really didn't want to, you're not going to get messed up. I don't want to say sued. You're not going to get sued or screwed or messed up because you didn't do it. You don't have to do it in low-risk women. If you find it that they need to be treated immediately, you don't have them come back for a confirmatory test, even though there's a high chance it's false positive. The rate of gonorrhea in the country is less than 0.5 of 1%. So it's just easier to treat them if they're not allergic to everything, and then retest them in 3 months. And again, if they remain at high risk because of partner status and those previous risk factors, you retest them in the 3rd trimester. Again, we mentioned yesterday, the treatment is now no longer just a cephalosporin, it's a cephalosporin and azithromycin. The reason it's a cephalosporin and azithromycin, as I mentioned yesterday, was number one, the dual therapy decreases the risk of having a resistant organism that survives and develops cephalosporin resistant, which we don't want to happen. And they know that your chlamydia tests are inaccurate 50, 60, 70% of the time, so they don't trust, they don't care if you got a chlamydia test that was negative. You're going to go ahead and treat them for gonorrhea and chlamydia because the co-infection rate's about 25%. Again, when they say they have a serious cephalosporin allergy, the answer is spectinomycin. Spectinomycin is not available in the United States. I have it because I treat other things with spectinomycin. I have just my own little box. I now have it at home because I figure when the world ends and we can't get medication, I have everything for anthrax, all kinds of diseases. I store medication. I'm a I don't know what not a fatalist, but I think that there's going to be a survivalist. Yes, I want to get a small place 2 days walk away from my house in Pennsylvania with a 1 acre land with a little house that's unassuming in the middle, a little log cabin, and underneath it I put all my stuff in there. And I tell my neighbors that, and they go freaking out, and they say, well, can we come to your place? And I said, I'm not going to tell you where I am. And then you're supposed to get a gun. And they said, well, you really shoot us if we come and try to get your water. And I said, no, I'm not going to shoot you. But because when I came from Oklahoma, and when I first got to New Jersey, and we walked in the beach, and they said, isn't that a beautiful view? Look at your house, and you walk down to the beach, and there's a beautiful view in New York. And I go, oh, no. And she goes, what's the matter? I said, if I can see New York, then I'm too close. If something happens, I don't have time to get to my bunker. I don't have time to get down, into my thing. But so I was spectinomycin. Going back to the lecture, you can't get a hold of it. So if you're really cephalosporin allergic, they want you to call somebody that's you can call any infectious disease specialist, and we'll give them azithromycin. We'll also the other infectious disease people will give a quinolone. I don't give quinolones. I'm on the anthrax committee for the Department of Defense for pregnancy. I'm there for pregnancy, and they always say they recommend Cipro for anthrax, and I say I don't like to use it in pregnancy. They say, listen, the risk is low, so we want you to use that. I said amoxicillin covers it. And they go, not the one that we've created. So the one that was released a few years ago, I'm on that committee and say, no, you can't you can give them amoxicillin. They go, no, we know it's resistant to amoxicillin. It looks like initially it's sensitive to amoxicillin, but it doesn't. It isn't. I said, how do you know that? It says because the one that was released was stolen from our labs, and that the whole story unfolded that someone at the lab, took it out. So, I'll go ahead and give azithromycin. Again, we talked about yesterday again. It's a higher dose. That higher dose gives them lots of nausea and vomiting. But I'd rather do that than give them a quinolone. Other infectious disease people will give them a quinolone. But I just don't like giving, I don't like to give a lot of things in pregnancy. I don't even give metronidazole in pregnancy. When I go to my infectious disease lectures, they always have somebody to do a point counterpoint, or I'm always on the side of don't give them all these medications, and I always lose, but that's how I feel. The BV has changed, and it's changed back and forth and back and forth and back and forth. You don't have to routine screen asymptomatic pregnant women that are high risk for preterm delivery. The last recommendations were you should screen people that were at high risk. So high risk usually is previous preterm delivery. There's a very nice study done. If you had a previous preterm delivery and you didn't treat it, you had a 40% return of your preterm delivery. If you treated them with metronidazole and erythromycin, then you would go ahead and have less than 25% chance of preterm labor. Big study published in the New England Journal. The problem is they tried to repeat the study over and over again. If it's not part of a gigantic NIH trial where everything's controlled, you're not going to get the results. What's the definition of BV? How do you diagnose it? It's not like you can take a culture for gonorrhea or chlamydia or test. So the new studies were treating things that weren't BV. In Europe, there's something called, and in my practice, aerobic vaginitis. It's the vaginitis you get when it's not really BV. Probably in the original study, the reason it worked is because you had your mixture of aerobic vaginitis and bacterial vaginitis, but the erythromycin took care of the aerobic vaginitis. But the new recommendations, because the data is so confusing, is you don't need to do routine screening in asymptomatic women, even if they're at high risk for preterm delivery. I'll do it, but I'll do it in a sneaky way. I'll just check a pH. If the pH is abnormal, I'll look under wet prep. Under wet prep, I see things that are suspicious, and then I'll go ahead and talk to the patient, and they'll tell me they don't have any symptoms. A lot of the women, and you all know this, they say they have. You say, "Gee, I see a discharge. How long you had this discharge?" They go, "What discharge?" I'm always like that, and I said, "Oh, it's probably not normal." And I look at it. So then I get done, and I said, "Gee, I think you have BV. I think you have trichomonas. I think you have something, but I really don't. Don't screen you. I'm not going to treat you because you're asymptomatic, and the data shows the data is inconclusive." And they go, "What are the symptoms?" I said, "A discharge, an odor, stuff like that." Within 24 hours, guess what? I have a discharge. Guess what? Even before they leave, "Oh, I've got that. I've got that. I want all the testing and treatment." So they'll all have that. And for me, for trichomonas, and I play dirty, I'll bring them over to the microscope and say, "Look at that. See those little things? Those are little organisms. Those are little animals, and they're inside you, and they're growing." And they go, "Oh, get rid of them. Get rid of them." I said, "So you have symptoms?" "Yes, I have symptoms." But officially, you don't screen asymptomatic patients. And it's the only time you get caught is the way you code it. You code as symptomatic. You code a vaginal discharge. You code something that's symptomatic, and no one will bother you. You say routine screening, you're going to get picked on. Bacterial vaginosis, treatment in pregnancy. Again, if they're symptomatic, you treat them all, because the older studies show there's a link. Now, the older studies also show if you use vaginal clindamycin, you had an increase in bad outcomes, and that's because when you give them vaginal clindamycin, you kill your lactobacilli. You kill your lactobacilli, and the few group B strep and the few E. coli and the few other things that were sitting around there now grow. And in the studies, when you looked at the clindamycin, they took that large study, they went back and saw that this happened. The people with the vaginal clindamycin had an increase in E. coli, because clindamycin doesn't cover gram-negatives. That's why you give them Clinda and Gent. And they had an increase in E. coli deaths in the baby. So the older studies said don't give it. Newer studies demonstrated that it's probably safe. I don't think so. I don't think that they really screen for the right things. So I don't give them vaginal clindamycin in pregnancy. Again, the CDC does this because if you do and something bad happens to the baby, you're not going to get sued. So I think it's nice that they do it, but between you and I prefer not to do it. You can give oral clindamycin. oral clindamycin doesn't cause an increase in your preterm labor and your fetal death, because only 1% goes to your vagina. So you're really not doing anything. That's why 50, 60, 70% have their BV come back, because you're really not treating it successfully and effectively. But then again, I'd rather you do something that doesn't work than do something that's harmful. So the same thing with Metrogel. When 3M used to have it, and when it first came out, I used a lot of it, but I used a lot of it for different reasons. And then they said, well, we want you to be a speaker, and we want you to go out. And I went out the first time and said, fine, I'll speak for you. I was in chairman at Minnesota, and 3M's in Minnesota. And the first lecture, somebody asked me, why'd you like topical medications of the vagina, for why do you like Metrogel? I said, it's only 37.5 milligrams. So it really doesn't do anything. So I'd rather use something that doesn't do any harm, that really does it, that's strong enough to do any damage. And then so I was never a speaker again. So so oral therapy has not been shown to be superior to topical therapy. BV and symptomatic BV in causing cure preventing outcomes. So symptomatic can be treated with either vaginal or oral. Again, the CDC is being very nice, because there were several lawsuits. You have somebody with a 40% chance of having an abnormal outcome. They got clindamycin vaginal cream, and the doctors were getting sued because they shouldn't have used that. Again, even the best studies, you only reduced your risk from 40 to 50% down to 25%. So they really decided it's the fact that they're premature, have a history of premature and high risk, not that they were getting the clindamycin, although it did wipe out their lactobacilli, and babies that did get sick got sick, but it was a relatively small number. So meta-analysis says there's no antibiotic regimen that prevents preterm delivery with people with BV, symptomatic, asymptomatic. That's not the same in Europe. In Europe, everybody gets screened for BV. In fact, what they do is they have gloves, and the middle finger has a pH strip on it. Everybody in Germany gets this. They give them a bunch of gloves. They go home. They say, check yourself every week. And if it comes back positive, if it turns blue, you call your doctor. It's all socialized. The doctors know. Patient calls up. They come in. They evaluate them a wet prep for BV, and if they have clue cells and the pH is elevated and there's an odor, they go ahead and they treat them, and they have a 10 to 12% lower preterm labor rate than we do. Whether it's because they're Germans and they're tough and they do not let the BV get in the way, or if it's because of the treatment. I think it's a treatment. I've tried to bring the gloves over here. No one likes it. The doctors don't know what to do with the result. Patients are always, having false positive. I'm now working with another group trying to come up with a home test. It's the same thing. Instead of doing the pH on a glove, putting it on a pad, and it's now being sold over the counter. I don't own any of it, but it's being sold over the counter at Walgreens and places like that. But the FDA is asking us to do studies to show efficacy. So we're going to start those hopefully in a month or two. One study did show oral BV therapy reduced the risk of late miscarriage. Okay, late miscarriage is too early preterm delivery, so I think it's all related. And in two additional studies, therapy decreased adverse outcomes in neonates. So I think searching for and treating BV is important, and I would treat them orally for now. Evidence is insufficient to recommend. Now, I want to qualify that. You can use the Metrogel, the metronidazole vaginal, because it doesn't. It just gets anaerobes. It doesn't get the gram positives, so it doesn't cause an increase in your E. coli, in your gram negatives, and so that appears to be safe in pregnancy. But the vaginal clindamycin I wouldn't use. So again, in summary, as the evidence is insufficient to recommend routine screening, they don't say it's not there. They don't say it's not good. They don't say it's, you shouldn't do it. They just say the evidence is insufficient to recommend screening, and asymptomatic women are high or low risk in presentation. Again, it's a caveat for them to let us have this discussion where I think it's insufficient, but it's hard to do those studies, and there's not a lot of money in those studies anymore. Trichomonas, evidence doesn't support routine screening. Trichomonas in asymptomatic women, that's why I talk about it. I see it. I tell them what the symptoms are. I really do actually bring them to the microscope. the first thing they besides going, ooh, and then I said, it's a little small animal inside you. The second they say is, where did I get it from? And I go, your partner. And then they want to go out and just say, I'm going to kill that guy. And I know, but they really do believe it. So when she goes home and he goes, no, your doctor's crazy. She goes, I saw it. I saw the move. And so I get a pretty good response and follow-up rate. And again, but women who report symptoms, you really need to evaluate them and treat them. One trial says that the possibility of increased preterm delivery in women received metronidazole. Chris Carey, it's a New England Journal article. He published it. I asked him why does he think that. He goes, well, he's a Texan. He goes, those little critters, when you kill them, they release these toxins and it causes preterm labor. I go, you really believe that? He goes, no. And so he went back and looked at his data, and it's the same thing. You give them oral metronidazole, and you do affect the flora a little bit. And it was the change in the flora from a good balanced flora that they tolerated and got away with an imbalanced flora because of the antibiotics, and they were increasing in their pathogens that came because of the exposure to metronidazole. It's a pretty high dose. Again, larger studies haven't found that adverse outcome, but again, I don't think the studies were done well. Again, the CDC is being nice, giving you lots of options. If you happen to give it, you're not going to get in trouble. If you're going to treat them, you treat them with 2 grams orally in a single dose. Again, this is symptomatic. The bad outcomes with symptomatic disease are documented. The bad outcomes treating asymptomatic, it's probably not worth it. The risk does not outweigh the benefit. But again, do it my way, get them all to be symptomatic, and you can treat them. So, data from use in tinidazole is limited. So again, there's tinidazole reps. They're out there saying how great it is. It is a great drug. It eliminates 99% of metronidazole resistance. Most recurrences are failure to treat the partner. Failure to treat the partner who's getting reinfected. It's not resistance. There is a 6 to 16% relative resistance rate, but I limit tinidazole. Tinidazole is a much, much longer acting, stronger nitramidazole, and animal studies should suggest that there's moderate risk. And therefore the CDC tells you tinidazole should be avoided in pregnant women, and breastfeeding should be deferred for 3 days because it lasts longer than the 2 days after a dose of metronidazole. So following a single dose of 2 grams, the breastfeeding needs to be, pump and dump your breast milk for 3 days. And again, the CDC is very clearly that you should avoid using tinidazole in pregnancy. Okay, and then they give you a referral to ToxNet at the NIH. Herpes. We have an hour for this talk, but I want to get you out a little earlier. Herpes is you're not supposed to do routine blood tests for herpes in pregnant women, asymptomatic pregnant women. I do on all my patients because I have a referral practice. They come to me for this, but there are instances when you should. So they're helpful in identifying pregnant women at risk for herpes infection. So newly married, this is what it usually happens. Newly married, the husband then is nicer husband, getting along with his wife, cares about their first pregnancy, and says, oh, by the way, I have herpes. She says, well, I don't have herpes, and oh my God, what am I going to do? And they get referred to me. And so he's got herpes, at least I think he has documented herpes. So I check him, but at the same time I check her. And then I say, we reconvene. If he has herpes, there's a 25 to 50% chance she already has antibodies. Remember, 90% of people that have herpes type 2 don't know they have herpes type 2. They think it's recurrence, we talked about yesterday, recurrent yeast infections, little fistula, rough sex, stuff like that. But 90%, and we did the study for the herpes vaccine, we just extensive NIH trial, 90% don't know they have herpes type 2. Of those, 25% do, that's the general population. If you have a partner that you've been seeing him for a couple of years, there's a chance he's already caught it. And she's one of the lucky 90% that don't have overt, blatant infections. So test him, he's positive, test her, she's positive. I say, don't worry, you're fine. She goes, what do you mean don't worry? I got herpes. I said, you have herpes. If you were a 18-year-old male, gorked out, brain dead with a high fever in the ER, our ER people, what do they have? Yeah, and herpes is one of them, and you consider herpes encephalitis and herpes meningitis. So it kills people. It doesn't kill people here because you develop antibodies. So I tell her, every heartbeat that you have, every pulse that's going to your babies is filled with, IgG, is full of antibody. And so you're inoculating your baby with a vaccine every pulse you have. Your baby will never die of herpes as long as you're not immunocompetent. The New England Journal article that 20 years ago that stated that women with herpes, have babies that die, and it was a 3 to 4% rate. I reviewed that paper, and there's not a 3 to 4% rate. It was a 0% rate, but the confidence interval was 0 to 4%. And so everybody, those of you who are old enough, and not many of you are old enough, we used to screen everybody for herpes, cultures the last 4 weeks if they had a history, and if you have to have 2 negatives before you could deliver vaginally, and therefore they became like a 60 to 75% positive C-section rate in those places. We don't need that. We now know that they've got antibodies. They don't, so I tell them, you're going to be okay. However, you all know if they have active herpes at the time of delivery, we do a C-section. Why do we do a C-section? Because her antibodies are strong enough for her not to die, but they're not strong enough for her not to have a lesion every 3 months or a problem. And that baby comes through, and that lesion's on the baby's eye, eyelid, forehead. That baby has that mother's protective antibody. You don't want your baby having a lesion every 3 months. So we do, if they're active herpes, we do a C-section. But I can convince them they're not going to die. The opposite is, so now he's positive and her tests come back negative. Fortunately, she hasn't caught it from him yet. What do I tell them? You don't have sex the rest of the pregnancy. They look at me like, what? I go, don't have sex the rest of the pregnancy. I said, if you catch it, if you get your herpes within 5 days of delivery, there's a 90% chance that baby's affected, 50% chance that baby's brain dead, and 50%, 40 chance that baby's going to die because you have no protective antibody. Those babies die. The same thing happens with chickenpox. If they get chickenpox around time delivery, someone comes in, they got chickenpox. I delay that delivery at least 5 days, hopefully 10 days. I don't deliver them because I want the mother to develop antibodies, that antibody get through the placenta, and they have a better chance. Unfortunately, the first antibody that they develop is IgM. IgM is a macromolecule, it doesn't get through the placenta, but they do develop some IgG, that's undetectable to test, but seems to help the baby in 5 or 6 days. So if someone comes in, so going back to herpes, and you ask them if they had a history of herpes, I ask them, does your partner have a history of herpes? And if they do, then I do the screening test. Otherwise, routine screening is not recommended. And the absence of lesions in the 3rd trimester, the routine cultures we talked about are no longer necessary. Herpes serology, we talked a little bit about this yesterday. I just want to show you the data. College of American Pathology, who kind of supervises all the pathology labs, sent 172 blood samples to their labs that are approved to do testing. They've put HSV1 antibodies in there and no HSV2 antibodies. The lab results were 99%, did a great job, detected the HSV1 antibodies. 50% incorrectly identified the HSV2. Now, yesterday, remember I said 88%, the test 88% inaccurate? Well, if you use the good test, the test that costs $15, you got it right 90% of the time. If you use a test that costs $5, you got it wrong 88% of the time. So if again, the CDC goes into, here's a list of the tests. Elvis is called one of the tests. Here's a list of tests. These tests are accurate. These other tests aren't accurate. And it's really not nice to tell your patients they have herpes When in herpes type 2, it's 88% of the time you don't have herpes. Group B strep, we talked about it. The only difference is that women, you screen at 35 to 37 weeks. If you have previously delivered a baby with Group B strep, you've got bacteria, Group B strep in this current pregnancy, then you don't need to screen them. You automatically will treat them. You probably get the results routinely, but then if the result comes back negative, it doesn't make a difference. You've got those things. You're gonna go ahead and treat them. So even if it comes back, so remember urinary tract infection. That's why the CDC and the U.S. Preventive Task Force says don't do a dipstick that says you've got a UTI and treat them, because you don't know if it's a Group B strep. You want to screen, and if it's a Group B strep, and it happens about 5% of the time, you want to treat that woman during pregnancy. There's probably a 30 to 50% chance that one test you do 35 to 37 weeks is going to be translating negative. Then you'll falsely think she doesn't have it, and you won't give it to her. So there are people that fall through the cracks, and this is where some of the cracks are. The other cracks are if they go into labor before 35 weeks, but in that case, then you automatically treat them, and you err on the side of protection. So again, if you have fever, if you didn't get your Group B strep back yet, you got a fever during labor of 100.4 or greater, even with a negative test, or you have ruptured membranes for 18 hours or longer, you're gonna treat for Group B strep. Again, I like amoxicillin. Other people think penicillin. The theory, you give penicillin because it's more specific and more direct. Again, I don't like E. coli. I got an E. coli that's locked up, hopefully better than they locked up the smallpox, that has a genetic defect that attaches to membranes and causes preterm labor and fetal death, and that's under lock and key. We're trying to go back and study it. So when you give them penicillin, it's great for, there's no resistance to Group B strep. When I was a young fellow, I thought I had all these resistant Group B streps, and I present at meetings, and every time they'd knock me down and say, no, you picked up the wrong colony on the plate. And I went back and tested, and there's no resistance to Group B strep to penicillin or amoxicillin. The problem is there's resistance to E. coli in 50, 60, 70, 80% of E. coli to penicillin. So you take this E. coli, and what you do is you go ahead and introduce it to penicillin, to beta-lactam, and the E. coli says, fine, I've got this beta-lactamase penicillinase molecule that I haven't been using because I don't need it. I'm going to turn it on. Now I'm resistant to now I got all this resistant E. coli, and it's not so good. Amoxicillin will kill 50, 60% of E. coli, so a dead E. coli isn't going to develop resistance. So I'd rather kill 50, 60% of them. And I've kind of collected data over the year and show wherever I go, I change the protocol from penicillin to amoxicillin, and we seem to have a little decreased rate. It's just there's so many numbers, it's hard to get to do it, but I believe in it. Penicillin allergic, you're supposed to ask them, what's your allergy to penicillin? If it's not anaphylaxis, you can give a cephalosporin. It really doesn't matter to me. The cephalosporins don't really work that well anyway. They kill it in the laboratory, but not in the people. If you have Group B strep, you give them a cephalosporin. And the number one organism when you have postpartum meningitis is Group B strep. It doesn't really kill it. It may suppress it enough for the baby, so I think that those recommendations are fine. We're getting a lot of resistance to clindamycin. Remember, if you're looking for Group B strep and the patient is pregnant, you will not get a sensitivity unless you say the patient's penicillin allergic. My laboratory is really suspicious that because 100% of my pregnant women have penicillin allergies, but I get a sensitivity back, and it comes back resistant to erythromycin, resistant to clindamycin, and I know what I've got to do. So it's a little trick if you're going to screen them in pregnancy. Just have them check off they're allergic. Yes, ma'am. Yeah, I'll show that slide. I think the question was, do I use amoxicillin for the UTI? Right. Yeah, if it's Group B strep, it's the best thing. So what I do, if I get someone that comes in, and I'll show you in a second, I get someone that comes in with pyelo, I always tell the residents, get a gram stain, from the urine. They spin it down, they get a gram stain, 2 hours, I get a gram stain, it tells me gram-positive organism or gram-negative organism. If it's gram-positive, I start on amoxicillin. If it's gram-negative, they get cefazolin, Ancef. So, get UTI. Most common bacteria are E. coli, Group B strep, and E. coli 80 to 85%, Group B strep around 5 to 7%, Staph saprophyticus, if your lab does speciate, they usually just say Staph species non-aureus, and you think it's Staph epi and a contaminant, but it's really Staph saprophyticus. But E. coli is the main thing. So asymptomatic bacteria, you screen in pregnancy. It's an easy number to remember. Your rate of asymptomatic bacteria, which is greater than 100,000 organisms in your urine without symptoms, is 1% per decade. So if you're 20, it's the 0 to 10, 10 to 20. If you're 25, 25. So you're 3%. If it's 30, it's 4%. So it's low. But if you have asymptomatic bacteria, your chances of having a preterm labor, preterm delivery, something go wrong, is increased 19-fold. So that's why you screen for asymptomatic bacteria. I use a culture. If it's Group B strep, they get treated. I treat with amoxicillin, and they automatically get Group B strep. Prophylaxis and delivery. Don't use Bactrim. It's just there's a lot of resistance. If they have repeated infections, even if it's a Group B strep, if it's sensitive to nitrofurantoin, I think it's a little safer to use. You're not inducing, it stays in the urine, you're not inducing different resistance in the entire body. Pylo, again, like I said, gram-negative, cefazolin, gram-positive, ampicillin, after a pylo, they get prophylaxed for the remainder of the pregnancy. If I can do it with nitrofurantoin, that's great. I think we'll stop there and ask questions. The rest of the varicella and CMV, it'll be in the lecture. Hydrops, what you do for hydrops. Toxo, everybody's got a cat. They all want you to check. I always tell them the easiest thing is just tell your husband you're not allowed to touch the cat litter box and make him do it the rest of the pregnancy, and do that. The testing is very, very unreliable. It's the type of thing, so that's where I get my spectinomycin from. The treatment for it is not available in the United States, so I have to get it from the FDA. What I do is I have a research study for one patient, but the FDA won't release the drug to me until it goes to their laboratory, one laboratory in the country. Otherwise, they won't release it because they do not trust any other laboratory in the country. And parvovirus, about questions. I want to get you out on time. Yes, ma'am. Mycoplasma. I think mycoplasma is a problem. I just had a unfortunate pediatric resident who had in vitro twins for the third time, who just miscarried with a cerclage, and it was ureaplasma. The difficulty is that it's there 50 to 60% of the time. So it can be one of the organisms that hangs around the vagina. But I think if it's a newly acquired infection, the body hasn't developed immunity or resistance to it, so it can be a problem. They've done literally hundreds of studies, and if you look at amniotic fluid from people in preterm labor and having problems, there is a higher rate of micronuria. It seems to be a problem. The in vitro people treat everybody with doxy or something ahead of time to get rid of the mycoplasma and ureaplasma instead of culturing it and then having to get it back and culture them again. But I think that there's 60%, 50 to 60% positive in people with a bad history and a bad outcome in their previous pregnancy. I think 10% of that or 1/5 of that, so 10% overall, is because of the micronuria. So I address it. I think it's important. It's very hard to because you'll culture, it'll come back over and over and over again. You want to treat the partner, you go back. But I think that, I do look for it and I do try to treat it. No, I wait till there's a bad, because you're going to see it in a high, you'll see Group D strep, the number one organism outside of your normal organisms in the vagina is now, we're doing the study, is Group D strep, Enterococcus. And that's why when you give them a cephalosporin for prophylaxis and they get a postpartum endometritis or something else wrong, it's usually a group D strep because it's there and you've suppressed everything else, and cephalosporins don't kill Enterococcus. At that point in time, it's a problem. You got to treat them with a penicillin to get rid of it. Otherwise, they have a 3-day hospital course with fevers instead of it's gone in 12 to 24 hours. When I was a fellow, they didn't think group D strep was a pathogen. So we did the abscess studies where we put different organisms, E. coli, group B strep, group D strep, with anaerobes in a mixture and injected into animals' abdomens, and group D strep can cause problems. So I think ureaplasma in certain circumstances can be the cause, but otherwise it can live there as a natural commensal. The big thing for you on your test is atopobium is related to BV now, and it's good because if you have BV symptoms and you're premenopausal, atopobium could be a problem and you treat it. But when you're menopausal and your lactobacillus goes away and your pH goes up, atopobium is your natural bacteria, because not all menopausal women have horrible vaginitis, and that's because they have atopobium. When I looked into it, atopobium is a new name. The old name for atopobium is Lactobacillus vaginalis. So it's the menopausal bit. So when you get a test from MDL or some laboratory saying you got atopobium and you got to treat it, if it's premenopausal, I would if they have symptoms. If it's postmenopausal, I say leave it alone. Any other questions? Otherwise, it's a beautiful day, and we'll see you tomorrow, right? Ronnie, you're coming back tomorrow, right? Yeah, we're coming back tomorrow. Thanks.